Welcome to the Deep Dive. We're here to take complex topics, break them down, and give you those key insights you really need. Today, we're diving into something absolutely vital for orthopedic residents, especially if you're prepping for exams like the FRCS or your fellowship boards: femoral intertrochanteric fractures. We're aiming for a quick but deep understanding, hitting the key concepts, the tricky controversies, and the practical stuff you need to know. And just so you know, everything we're covering today comes from the fantastic Ortho Made Simple notes. These were put together by Dr. Mok Ying Ren, a sports surgeon over at National University Hospital in Singapore. He got his FRCS back in 2022. You can find all these notes on mokyingren.sg.
That's right. And inter-trochanteric fractures, well, they're everywhere in orthotrauma, aren't they? The decisions you make here are really critical for patient outcomes. So our mission today, if you like, is to clear up the classification, talk about immediate steps, really get into the surgical choices, DHS versus nail, and then how to tackle complications. It's about getting that solid foundation for exams and, just as importantly, for your actual practice.
Okay, let's unpack this then. You're on call, the x-ray pops up, it's an IT fracture. Before anything else, you're thinking classification. Why is getting that right so fundamental, and how do we actually categorize them?
It's absolutely foundational, you're right, because how you classify it points you directly towards the treatment. So primarily, we think about it in two main ways. First off, stability. This is key. Is the fracture pattern likely to displace under normal load, or is it inherently stable? We need to know the unstable factors, things like a reverse oblique pattern.
That's where the fracture line runs kind of diagonally down and out.
Exactly. Or if there's subtrochanteric extension, the fracture goes down into the shaft. Also transtrochanteric involvement, or losing that crucial medial calcar support.
The strong inner bone bit.
Yeah, that dense strut. Or losing the lateral buttress, that strong outer wall. If you have these, the fracture's unstable. It means it's much more likely to collapse or fail if you don't use a really robust fixation. The second way is thinking about the number of parts. The Evans-Jensen classification is often mentioned here. It goes from type 1, undisplaced, up to type 5, which is a complex 4-part fracture, involving both trochanters. And then, of course, there's the AO classification. You'll see this everywhere. For the proximal femur, it's 3.1.A, and then A1 means stable, A2 is unstable, and A3 specifically flags those really unstable reverse oblique or transtrochanteric types. So the AO system, it kind of incorporates that stability idea directly.
That stability distinction sounds like the real core of it. Okay, so we've classified it. We understand the stability. What about immediately? What's the very first thing acutely? And is there any place for temporary traction anymore? We used to hear about it.
That's a really practical question. And the answer, based on good evidence, is pretty clear now. Basically, no. There's no real role for routine temporizing traction. Multiple Cochrane reviews, Martin Parker's group did some key ones. Back around 2011, they looked specifically at this. They found zero evidence that putting someone in traction before surgery helps with pain, makes the reduction any easier, or improves how well the fracture stays reduced.
So it doesn't really offer any benefit?
Pretty much. It adds hassle for the patient, maybe some risks, without a clear upside. So the consensus is just don't routinely do it. Focus on timely surgery.
Okay, got it. No traction. So let's move to the OR. This is where the big debate happens, right? The dynamic hip screw, the DHS, versus an intramedullary device like a nail. What's the thinking here? Why choose one over the other?
Yes, the classic DHS versus nail discussion. It really gets to the heart of managing these. And biomechanically, there are theoretical advantages to the intramedullary devices, the nails. Because they sit inside the bone canal, they have a shorter moment arm, or lever arm. The forces are closer to the implant's axis. So theoretically, they should handle unstable fractures, like those A3s, better. Plus, a nail, being sort of tubular, is inherently much stiffer against bending and twisting forces than a flat plate like a DHS. Think bending a pipe versus a flat bar.
Makes sense biomechanically.
It does. However, and this is really important, especially for exams, theory doesn't always perfectly match clinical reality for every fracture. Martin Parker's group, again, a 2018 meta-analysis in the Injury Journal, looked at A3 fractures, those tricky reverse oblique and transtrochanteric ones. They actually found comparable healing and complication rates between DHS and IM nails for those specific unstable patterns.
Really? So the nail wasn't definitively better in that analysis?
Not definitively, no. Which forces us to think a bit more critically than just saying unstable equals nail. It's a key discussion point. Now, that said, in current practice, if you have a clearly unstable fracture like Hajdukwich described in that J.O.'s TIPS paper, reverse oblique, transtrochanteric, subtrochanteric extension, lots of lateral buttress, loss of medial calcar, yeah, most surgeons will lean towards an IM nail because of that inherent strength. Yeah, but you also have to be aware of a complication more specific to nails, especially in weak bone, cut in. The stiff nail can actually cut through the softer head bone, sometimes right into the joint. Not good.
Ouch. Okay. And you mentioned TAD earlier, tip apex distance. That applies to both.
Absolutely critical for both. For a DHS, we're aiming for a TAD under 25 millimeters. That's thanks to Baumgartner's classic 1995 paper. For an IM nail, the target is usually a bit broader, maybe 20 to 30 millimeters. Getting that screw or blade tip in the right spot in the head is paramount to prevent failure.
Let's dig into DHS failures a bit more. You mentioned reverse oblique fractures being tough. How exactly does a DHS tend to fail in that specific pattern? What's happening biomechanically?
Right, so for reverse oblique, the fracture line runs down and out. When the patient puts weight on it, the main force isn't nice axial compression along the screw. Instead, you get a huge shear force across that angled fracture line. And importantly, you've often lost the lateral buttress support in these patterns. So there's nothing stopping that proximal fragment from just sliding downwards and outwards along the fracture line. The shear force basically overcomes the screw's hold in the head, and it collapses or cuts out.
So the direction of the fracture line fundamentally changes the forces on the implant.
Precisely. And that brings us right back to Baumgartner's 1995 paper. It's a landmark study. They looked at almost 200 fractures, found 19 failures, and 16 of those were cutouts. The average TAD for the ones that healed was 24 millimeters. For the ones that failed, 38 millimeter. And the killer finding, none of the screws with a TAD of 25 millimeters or less cut out. That paper basically established TAD as the critical factor for DHS success, especially avoiding cutout.
Wow, that's stark. So precision really matters. Thinking about actually doing the surgery, any quirks or tips when putting in a DHS, like does left versus right side matter? And what about the little details like plate holes or barrel length?
Good questions. Yes, there's a subtle point about left versus right DHS insertion. On the left side, as you tighten the lag screw, the rotational torque can sometimes cause the proximal fragment to displace anteriorly, creating an anterior spike. Not ideal for reduction.
Ah, okay. How do you stop that?
Couple of tricks. You can put in a temporary K-wire to hold the fragments rotationally stable. Or some people advocate just a tiny reverse turn right at the end of tightening to counteract that torque effect. Just something to be mindful of on the left. As for the plate holes, 2-hole versus 4-hole, there was a biomechanical study, McLaughlin et al., back in 2000 in JOT. They found no significant difference in strength. So often 2 holes are perfectly adequate unless you need extra length for some reason. Now, short versus standard barrel length for the DHS, this is important and depends on your screw length. You choose a short barrel if your lag screw is going to be less than 85 millimeters long.
Why 85 millimeter?
It's about allowing enough room for the fracture to collapse and compress. You want at least 25 millimeters of potential sliding distance available. A standard barrel is 38 millimeters long. Add the thread length, around 22 millimeter, and that 25 millimeter sliding distance. You need about 85 millimeters of screw. If your screw is shorter, that long standard barrel physically stops the compression happening. So short screw, short barrel.
Got it. Makes sense.
And for the screw threads, you want them grabbing as much bone deep in the head as possible. But crucially, the threads must not cross the fracture line itself. That would prevent sliding and compression. Barrel length, generally, longer is better for resisting bending and allows smoother sliding. So you usually go long unless, again, it crosses the fracture or your screw is too short. And the plate angle, 135 versus 150 degrees, that's chosen to match the patient's natural neck shaft angle. You're aiming for anatomic reduction. But the one thing you absolutely, positively must avoid is varus angulation. Leaving the fracture in varus is bad news.
Why specifically?
Several reasons. It increases the bending moment on the implant, more leverage for failure. It tends to place the screw higher up in the femoral head, which dramatically increases the cutout risk. And biomechanically, it shifts forces towards bending the plate rather than compressing the fracture. Always aim for neutral or slight valgus, never varus.
Okay, so avoid varus at all costs. Taking all that DHS stuff together, what are the key goals for the reduction itself? And then flipping back to nails long versus short seems like another one of those it depends situations.
It often is, yeah. For reduction overall, the key indices you're looking for on the X-ray are positive medial cortical support, meaning the inner cortex lines up well or is slightly impacted, and achieving a neutral to slight valgus alignment. Get that right, and you give your fixation the best chance. Now, long versus short nails, it's debated. Some people argue for routinely using long nails to avoid potential stress risers lower down the femur, which could theoretically lead to a later fracture.
But the downside?
Longer surgery, more blood loss, definitely more invasive. And the evidence, well, a local study by Andrew Hong's group here looked at this. They found no real difference in clinical or functional outcomes between long and short nails. But the long nail group definitely had longer op times and lost more blood. So in our practice, the main driver for choosing a long nail is usually significant subtrochanteric extension of the fracture. How much extension? The literature varies. Some say even 1 centimeter warrants a long nail. But a really relevant study was the Channon et al. Bogle Award paper from JOT in 2018. They looked at outcomes defining extension as more than 3 centimeters below the lesser trochanter tip. They found similar results for short versus long nails, no difference in cutout, infection, or later fractures.
So even with significant extension, maybe a short nail is still okay.
It suggests that, yeah, up to a certain point at least. So while you worry about stress risers, the clinical data suggests maybe we don't need to default to long nails quite as often, especially given the downsides.
Really interesting nuances there. Okay, just pausing for a second to remind everyone listening, this deep dive is powered by those excellent OrthoMade Simple notes. You can find them at mokyingren.sg. Really useful for consolidating this kind of complex info. All right, moving beyond the standard fixation hardware, are there times we might think about adding something extra like cement augmentation? And then the tough one. What do you do if things go wrong, like if a blade or screw starts cutting out?
Yeah, good points. Cement augmentation in IT fractures. So lab studies, biomechanical tests, they do show it increases the strength of the construct, makes it harder to fail under load, maybe by 12% to 37%. But clinically, there's no broad consensus that we should be doing it routinely. Big trials, like one by Camerlander et al.,
Yeah.
an injury back in 2018, found it didn't really increase complications, but didn't necessarily show a universal benefit either.
So when would you consider it?
Probably reserve it for patients where you're really worried about the bone quality. Severe osteoporosis, maybe renal osteodystrophy, where the bone is just intrinsically weak, and you feel that extra stability might make a difference. It's a selective tool, not a routine step. Now, managing implant failure, like cut in or cut out, that really depends. First, the patient. Are they still active, symptomatic? If so, you probably need to intervene. Second, the fracture. Is it healed around the failed implant, or is it still mobile? The main options are essentially replace the whole thing or try to refix it.
What do you lean towards?
Well, our preferred options generally are either removing the failed hardware and refixing, maybe with something like an angle blade plate, which offers different mechanics, or moving to a total hip replacement. If you do opt for hip replacement, a key technical point is your stem choice. You need a stem long enough to bypass the most distal screw hole from the old implant by at least 2 cortical diameters. You got to get fixation well beyond the damaged bone and stress risers.
That sounds like a pretty major operation, doing a hip replacement for a failed fixation. A complex primary, almost.
Exactly. It's definitely not a standard primary hip. It requires serious pre-op planning. You need good templating, often CT scans, to really understand the bone stock and where the old hardware is. And crucially, you need to have the right implants available. Long cemented stems, maybe calcar replacing stems, definitely revision type options on the shelf.
And intraoperatively, how do you approach it?
We often use the EOR mnemonic to guide the steps. First, exposure usually need a good extensile posterior approach.
Yeah.
Second, explain getting the old metal out carefully can be tricky. Third, examine and reconstruct. Assess the bone loss, especially around the calcar, and rebuild it if necessary, maybe with bone graft or augmentation. Fourth, replace. Put in the new hip replacement, typically using a long cemented stem, sometimes cementless if the bone allows distal fixation. Usually full weight bearing is tolerated post-op, assuming you get stable fixation. But the principles are key. Use a revision type stem, not a primary one. Get solid distal fixation. Address any calcar deficiency. Usually means a long cemented or long cementless stem.
That's an incredibly thorough run-through. We've covered a huge amount, from why classification matters, the evidence on traction, that whole DHS versus nail debate, the nitty-gritty technical points for both, and then even augmentation and how to salvage failures. Really understanding all this is vital, isn't it? Not just for exams, but for making good decisions for patients day to day.
Absolutely. You know, in orthopedics, precision is everything. And that applies just as much to our knowledge as to our surgery. Understanding why we do things, the evidence behind it, the potential pitfalls, that's what builds competence and confidence.
Sure.
Think of it like this. Just like getting a good, stable reduction is the foundation for fracture healing, getting a deep, solid understanding of these topics is the foundation for your clinical practice. And yes, for acing those exams, it becomes your most powerful tool.
Couldn't agree more. This has been a fantastic deep dive. Thanks so much for walking us through all that. And for everyone listening, remember, this detailed discussion draws heavily on the OrthoMade Simple notes. You can find them and explore even further at mokyingren.sg. Definitely worth checking out. Thanks for joining us on the deep dive. Until next time, keep digging deeper